so Niskanen's a little bit unique in that we sit in sort of the middle of the political spectrum. What we like to use the phrase like transpartisanship to describe some of what we do and the way we approach it. And that's different than bipartisanship in the sense that bipartisanship is usually trying to find a compromise between two parties,
Okay. Yeah.
whereas transpartisanship is trying to find agreement between two parties where there's enthusiastic agreement about something on the left and enthusiastic agreement on something on the right. Usually, it's not necessarily for the same reasons, but they can come together. I think a good example in healthcare space is probably some of the price transparency work. This was something was started in the Trump administration, trying to make healthcare more of a market-oriented system by, removing some of the sort of cloudiness surrounding pricing. Started in the Trump administration. Biden administration has also sort of taken on the same mantle, increased enforcement of the rules that the Trump administration started. So in healthcare, it's a little bit different in the sense that you don't have as much sort of, I don't think, partisan bickering. It's usually industry versus Congress rather than parties against each other fighting over something. I think the ACA debate, you see a little bit partisan. I think anything over coverage tends to be partisan, but other aspects of the healthcare space are less so.
Okay. So when you're talking about the transparency, you're talking about publishing prices for the for procedures and other things like that. So to where it's
Yeah. So
easily,
that was
yeah,
the 2016 effort to force providers and insurers to reveal their negotiated rates.
yeah. Okay. And have you seen um, have you seen results? What have been the results of that sort of thing?
Yeah, so it's a bit complicated in the sense that we don't uh, not all hospitals are complying. Even when hospitals comply, it still requires a good amount of data work to get the price information into the hands of consumers that in a way that makes sense to them. So I think where we have seen some good is we have better data on negotiated rates. And what that does is that allows policy experts, it allows data folks to show to the public and to policymakers more clearly the sort of lack of consistency in pricing, even in the same geographic area. It allows folks to see how high prices exist primarily in the hospital setting rather than in an independent care setting. And that's really helpful for policymakers as they try to make decisions to lower pricing, realizing that there are very clear delineations in terms of there's high cost areas and low cost areas, there's high cost centers and low cost centers. And prior to the revelation of the negotiated rates, I mean, that was a trade secret. And so as those negotiated rates are revealed, we get a lot more information and intel on healthcare pricing. So in that way, it's good. I don't think we've seen any sort of impact on the customer shopping, customer saving side. I think I don't know. It's very difficult in a market like this where consumer behavior in terms of patients is really like sort of set. We how we approach our healthcare system is sort of set, and trying to convince a consumer to then change and start shopping for some of this stuff is a really difficult thing, even if the pricing's available. There's not a lot of good incentives for insurance companies to convince their patients to shop. It's that infrastructure is not there, so we're not seeing outcomes in that way yet.
But it's part of the model preference would be people spending their own money on their own health care. Obviously, that doesn't work if you've got a $50,000 medical bill. But in terms of getting a blood test, if you're paying with your own dollars and this organization is asking for $200 and somebody else will do it for 30, people spending their own money if they know the prices. So
Yeah,
the two go together. If you're not spending your own money, you're less concerned about prices.
100%. Yeah, that's definitely the case. And that's sort of in, I guess, in some of the ways that the behavior by consumers is locked in is just when you have a third party payer for most of these things, it is really difficult, to get consumers to think about sort of the value proposition in care. Obviously, for emergency care, I don't think we ever want necessarily consumers to be forced to think about the value proposition on their way to the emergency room. I think the emergency room is designed to care for emergencies, but for elective non-emergency procedures like testing, MRIs, even surgeries, You can save a lot of money if you shop around. It's easier to shop than it was, I'd say 6 years ago, um, but not easy enough. And because, like you said, obviously there's improvements in some of the sort of empowering patients ideas with HSAs, FSAs, like these things are helpful, but at scale, we're not seeing any sort of real shopping for care.
Yeah, when last time I've had, procedures, if I've had an elective X-ray or something like that, I usually call my doctor, who is a homeschool dad. He had a couple of his daughters in my club before, and I'll say, "Hey, I need to get this done. Who would you recommend?" And he's already done all the shopping, and he's saying, "Well, you go
That's
to
great.
here, and these guys will only charge you this much." And I'll call them up and I'll ask them, "Okay, so I'm looking at coming in. Doctor ordered this X-ray. How much would you charge me if I'm self-pay?" Because I'm on a healthcare sharing program. I'm through
Right.
Samaritan, and there's a bunch of other ones out there, or several others out there. And so back on the whole transparency thing. So you being a former debater and all of that, is there more that the federal government could do policy wise to make things easier, or is this now more? Is it still just so insurance driven that the consumers just don't even care? Is there some sort of thing that the government could do to create that incentive for the patients to want to shop around more?
Yeah. So I think I'd say two things. The first thing is I'd say there are successful cases models of where uh, programs to incentivize patients to shop have worked. I would encourage debaters to go back and look at New Hampshire model from 2016, where the New Hampshire state government decided to pass what I guess there's different terms for it. One is a right to shop program, others call them shared savings programs. This is giving patients an additional incentive for shopping. If a patient uses the program that the state created to shop for care for an elective procedure on the portal that was offered to them, they were able to take home a portion of the savings. So if they
Hmm.
could, if in their market there was a MRI that was $800 and they got one for $300, they would take a portion of that $500 difference in savings. Now, this was a program that ended up saving patients millions of dollars. Um, Similar programs have been tried in other states with not as much success. I think one of the reasons why it was successful in New Hampshire is that it was limited to the state employee health plan. That's a large self-insured plan. What that does is it sort of aligns the incentives across the board. That is that when a patient saves, not only does the patient save money, but also in this case, the state government, because they're funding the insurance program versus if they used a third party insurance program, commercial market, individual market, those you're not necessarily aligning incentives across the board. The insurer, the employer aren't necessarily all saving when the patient saves. So when you have those aligned incentives, I would highly encourage debaters to consider using the issue with this is sort of the federal government. So finding a federal government lever to encourage states to innovate in their state employee health plans. In a lot of cases, this is one of the largest health plans in the state. It's not a small impact measure. We're talking millions in savings. We're talking changing some patients' behavior because in those for state employees, you have those incentives aligned. You have strong communication networks. The insurer, your employer all want you to save, and so you saw some success there. I did a research paper that compared Maine and New Hampshire's programs because Maine's program was not very successful, and they didn't use a self-insured state employee model. They used the commercial market, and you saw less success. So that's that's definitely one of the ways that price transparency, which is these programs are better and easier as a result of price transparency efforts. I'd say applying it to the commercial market, like you said, with those insurance markets, it's much more difficult. You have huge risk pools. There isn't strong incentives on the employer side to get patients to save because they don't necessarily benefit. So a self-insured model, I'd say, is where debaters should be focusing.
Okay. What about opening up markets for insurance companies to be able to sell their health insurance across state lines? I know that there's some restriction on that. Would that go to help? Because I think that might be, is that not a federal issue in being able to let insurance companies sell across state lines?
Yeah, my understanding is a lot of that's done at the state level, but you can pull a federal lever on that. I do see some benefit to that for sure. I don't know. I think in this, and we can, this is sort of like a bigger question of like whether we in terms of issues that have the highest impact, I think is where, debaters should focus. And so among the issues that have the highest impact, I think a lot of them are actually less on the coverage side of things and more on the sort of supplier side of things. So we can talk about some of those things. So I would say, yes, I think that's like a meaningful reform, but I would definitely encourage folks to try to think outside of reforming coverage models and the way coverage is done and focus a lot more on the supply. So that's what I would say.
Okay.
So uh, in talking to homeschool students, if the topic were on education reform, you could focus on the structure of the education system, how the teachers are paid, or the school, or whether it's a local district or state, and where the funding comes from. Separate from that, but related, is the content that's actually taught in the classroom, which is really of major interest to the parents, particularly in the homeschool world. Now, in the medical field, we're structured, who's paying, third-party payment, employer, government, whatever, but also what's the content of the teaching, the service that the doctor provides. Now, obviously
Sure.
for surgery, broken bones, things like that, those are sort of set. But one of the things that I've been arguing is the medical model of just short visits and giving people pills for depression or for anxiety or for being overweight, rather than the separate school of thought that's saying, you're treating symptoms, not the causes. And we're seeing this in the news now about processed food, sugar, excess carbohydrates. I'm wondering if you yourself or Niskanen, or you see a model that has looking at the content of what's provided, which really requires new providers, right? People who are nutritionists, but not people from a nutrition college that's funded by, big food and big pharma, critics would say.
Yeah. So forgive me, I'm going to take a little bit of a bigger sort of take here, and then I'm going to zone in on that question. But I want to start big because I think it's important for debaters to understand the context, because there's a lot of debate about the quality of the US healthcare system. There's no objective metric to determine quality of a healthcare system. There's no way. I think I'm going to start here, and then I'm going to get down into some of these alternative models. The first is that I would encourage debaters to not focus a lot on high costs. And the reason is because we don't know how much we don't know what a reasonable spending on healthcare is. The reason I say that is because in America, we spend $12,000 per capita compared to the closest, I think, wealthy country is around 8,000. We spend way more on healthcare than even the other highest spenders on healthcare. But we also have one of the unhealthiest populations compared to those countries. We have higher rates of what I would call amenable or treatable. The OECD has a treatable deaths metric. Now, this excludes most lifestyle-oriented deaths. So that is traffic fatalities, even infectious diseases. It excludes lung cancer, which is, I think most consider sometimes a lifestyle-oriented death due to rates of smoking. It excludes even, other sort of lifestyle-oriented things. And in that metric, we are still have the highest rate of treatable deaths among wealthy nations. So there's clearly a problem with healthcare and not just health, if that makes sense. So our spending actually may be commensurate with the level of population health. But it's clear that we're not meeting people where they need to be met. And so I think a lot of this comes down to preventive and primary care. The US has a similar rate of specialists per capita than those other wealthy countries. And we're talking about mostly European countries, Japan, Australia. We have a similar rate of specialists. So that is people that focus on specialist conditions. We have the lowest rate of primary care physicians. This is important because primary care is usually the traditional way to avoid some of these treatable, amenable mortalities. Now, I do think that it's worthwhile to engage in the conversation about food, to engage in the conversation. I know there's a big Make America Healthy Again movement I think talking about those things is useful because there's a reason the US has really high rates of these things. But I think it's multifaceted. I think a debate over the causes of why we have an unhealthy population is not a healthcare debate. I think that is a food debate. I think that is a transit debate. I think that's a housing debate. I think that's a walkable cities even debate. If we force people to drive everywhere, they're not walking. That's not good for the health of the population. We have the highest rate of drivers in compared to those countries as well. I think those are important questions, but I don't think those are healthcare questions. I think the healthcare question is how do you then get providers, primary care providers, providers that specialize in preventive care into areas of need. And so, like you said, there are alternative models. I think direct primary care is a great example of an alternative model that focuses primarily on meeting patient needs. They can go to the doctor as often as they want for lower cost. We need to be incentivizing low cost models that emphasize the relationship between patient and provider. If you ask people, the rates of folks with a primary care physician has decreased in recent years. I saw a viral tweet the other day that said, my primary care physician is 2 urgent cares and a trench coat. I think that is the way that many people approach their healthcare now is if it's something really bad, they go to the emergency room, a very high cost, low efficiency area for care. And if it's not that bad, they go to the urgent care and they usually don't even see an MD. Nothing wrong with nurse practitioners, nothing wrong with physician assistants. But if you don't have a consistent relationship with a primary care provider who knows you, who can track you over time, who can identify things, oftentimes patients aren't even like getting their records transferred to other centers. Like this sort of kind of fractured, fragmented care as needed is not working for folks. So I think getting more primary care, independent care, direct primary care is a good example of sort of an independent model, doesn't take insurance, more flexible, more efficient as a result of that. I think getting those into the hands of folks is the most important thing to deal with the healthcare system.
Now, in the status quo, what I used to have, what I had my entire career until Affordable Care Act made it illegal, was catastrophic insurance. So I paid, when I was young, it was $50 a month. It had gone up to maybe $300 a month, and I was covered for anything over $7,000. And then there was a copay and so forth. But that meant that I paid all my own medical, visiting a doctor, treating a bruise or this or that. Those aren't legal, but those seems to me are a natural pairing with direct primary care. Because if I could now I'm on Medicare, but if I instead of that $800 going to Aetna, if that money went into buying catastrophic insurance and then some amount that I could use in a savings account, a health savings account that we used to have, that seems to me to invite in lots of direct primary care and relationships and people
Yeah.
taking care of it. It does seems to me it does so many things. So you
Yeah.
could have Medicare for all or Medicaid, Medicare for all if it was based on the direct primary care model. Wouldn't be that expensive if it was legal.
Yeah. Yeah, no, so and I think that goes hand in hand. So Niskanen has been a longtime supporter of what we've called universal catastrophic coverage, which is sort of a rather than a Medicare for all, it's rather sort of a federal safety net for healthcare. And then, for those who qualify for that, they get this sort of catastrophic coverage, and then everyone else is incentivized to sort of do what they need to take care of themselves. Usually, I think independent care would become much more popular under something like that. It's very unlikely. I think in the debate world, that would be a really fun thing to do because you can. In the real world, it's not possible. But in the debate world, that would be fun. I think a universal catastrophic coverage case would be really fun. Niskanen has a big paper out on it, and you could model the case after that. I think 2 other things on the direct primary care, just to take it into like the case realm. One is allowing HSAs to be used for direct primary care. That would be a great case. There's bills going through Congress on that. One of the things I'm working on the Hill is Representative Crenshaw's bill, which would allow state Medicaid programs to partner with direct primary care clinics to provide Medicaid to allow Medicaid to cover direct primary care. I think that would be a great idea. The bill, essentially what it does on the federal side, because Medicaid is a state enforced program, on the federal side, if a state wanted to partner with a direct primary care clinic, Michigan's the only state to have tried. They have to get a waiver from the federal government called a Section 1115 waiver. That waiver process is cumbersome, not always, but often cumbersome. And so the bill would essentially allow states to start immediately to negotiate with direct primary care clinics to develop a program without having to go through the waiver process. I think that's a great idea. Medicaid patients in particular, I think, are of most need when it comes to direct primary care. Those patients are much more likely to have higher rates of chronic illness, much more likely to have longer wait times for a primary care physician just based on where they're located. And so getting lower income, sometimes jobless folks to kind of incentivize them to go to a clinic where they can get as much care as they need. They get more time with a doctor to deal with sort of chronic illnesses. I think that is a great idea. And it's what I would call a way of optimizing the social safety net. Medicaid covers really high cost hospital care. Medicaid patients go to emergency rooms more often than other patients. Emergency rooms are the highest, hospitals are the highest cost, least efficient place for care. So being able to incentivize Medicaid to fund low cost, high quality care, low cost primary care, over time, that you come back with savings over time because less people are going to go to the emergency room as a result.
And it could be called the Singapore system too, because that they seem to have, they say 1/4 the cost, just as efficient. And it's basically the government's providing catastrophic care with tax dollars, and people on their own are forced to save up to what, 7 to 10,000, and they pay their out of pocket. And it's their own money. It's there that they spend.
Yeah, and obviously Singapore is a really concentrated market. I do think that different types of reforms work differently in markets. So for example, like even the healthcare consolidation that we're seeing in the marketplace, that's really negative. It isn't negative entirely for everyone. There are obviously places where a consolidated market isn't the worst thing. But in rural areas where hospitals are closing down and then, you have to drive 3 hours to go to your nearest inpatient, that doesn't work. So I think, the Singapore example is a good one. It's unfortunately not directly applicable, but I think the principles from it are, for sure.
If one of the things that you'd said earlier is that we have a high rate of specialists and we don't have really a good rate of primary care physicians, do you think something like Medicaid covering primary care, would that incentivize more doctors to move into the primary care? Because the general physicians are really down. There's not, nobody becomes a generalist anymore.
Yeah, because it's not lucrative. Yeah.
Yeah. Now, would that make it more lucrative, being that it's covered more by Medicaid, because they're going to negotiate prices that are going to be relatively low? Would that bring in more generalists, or do you think that would just overrun more of the the people that we have? They would end up being way too busy.
Yeah, so the good thing about direct primary care in particular is doctors start direct primary care clinics because they're burnt out from the hospital system or other care systems. So DPC is they can actually spend time with patients. So what I would say is you're right in that Medicaid covering something isn't a strong incentive. But what is a strong incentive is more options, more patients for direct primary care clinics, and essentially more marketing for direct primary care clinics. When you have a major like urban area where Medicaid patients are getting notes that say, "Hey, here are your direct primary care clinics. We just came to agreement with these 5 clinics in your county that you can now go to as many times as you want without any cost sharing on your end and get no wait times, same day appointments, walk-ins." I think Medicaid patients will take them up on that. It is obviously up to Medicaid state program managers to be really good marketers, and I think that's important. But that's sort of at a very low level of implementation strategy that I don't think debaters need to get into. But so I think it would be good for DPC, direct primary care. I think it will potentially lead to more doctors. The overarching problem though with primary care doctors is that in 1998 the federal government capped the rate at which we are producing primary care doctors. we cannot produce any more primary care doctors than we did in 1998. Well, they passed a bill that increased it by 1,000, which is nothing. So it's increased by 1,000 than it more so than it was in 1998. So every year, the amount of residencies that we can match with Medicare funding have been capped. And so that is a huge issue. And when those are capped, when you have a shortage, it creates higher and higher incentive levels for students to go into subspecialties, more lucrative subspecialties. So I think there's two things that need to happen. One is we need to incentivize primary care at the Medicare level, which I'm in favor of using that funding that we fund residencies for and use that to incentivize folks to go into primary care, whether that's increasing salaries, whatever it looks like. I think that needs to happen. And secondly, we need to restructure the way we finance residencies because it's clearly not working. So I think without those two things, we can definitely shift them. We can redistribute doctors, but we can't increase the rate at which primary care doctors are being produced without reform at the Medicare level.
Now, are residencies governed by the federal government, or is that a state government issue?
Residencies are funded by the federal government. They're funded by Medicare. So obviously, a state medical school is able to get residencies funded privately. They're able to fund them themselves. The idea when Medicare first started funding residencies was not that they would become the sole funder of residencies. I think the assumption was that private funding would also be a part of this, but that's just not the case. Medicare has sort of become the sole funder of residencies, and you need a residency to practice. You can build a medical school, but without a residency, it doesn't necessarily matter. So Medicare funding those residencies is really important.
So
okay, sorry about that. I want to follow up on this.
Yeah, no, go ahead.
Should it be a private industry for residencies to let the market drive that?
Yeah, so I think that's one of the problems is when you kind of create an artificial set for anything at the federal level, particularly in 1997, and don't adjust it for 20 years, that creates a problem. So regardless of who is setting it, it needs to be more flexible and able to. I mean, the main problem with our healthcare supply is it's inelastic. It's not responding to consumer demand at a rate that makes sense. Even after the ACA and Medicaid expansion, research showed that hospitals were not then responding to an increase in demand from people now covered that weren't covered before. They weren't necessarily opening up new clinics because there's so much restrictions on the level of doctors we're producing, the amount of clinics that we're able to open up. We have state level certificate of need laws that prevent you to even start a clinic without the hospital that's currently there taking you to court. So there's no incentives for a competitive marketplace that allow supply to respond to demand in a way that is commensurate. It's fractured, it's fragmented, and it's heavily restricted.
Yeah, so the H-1B visas to try to bring more European doctors over, that just hurts any medical doctors over here that have just graduated because they can't get residencies.
So it depends though. So what I would say is, if an immigrant if an immigrant has not gone to residency in another country, they have to repeat their residency here. They are much less likely than a domestic trained doctor to match. Domestically trained doctors have a much better chance of matching than an immigrant doctor. The problem is that we force immigrant doctors to repeat their residency when they've already gotten residency in another country. We have estimates are anywhere from 60,000 to over 100,000 immigrant doctors that completed a residency, have been practicing in another country, move here, and then can't get matched, and now have to drive Uber, work on medical coding, underemployed, unemployed doctors that should be working. And so I think one of the major problems is states need to, only 3 states have done it: Virginia, Tennessee, Florida, 4 in Illinois. Those states have started waiving residency requirements, because it's not like once you waive a residency requirement, an immigrant doctor can just get to work. They still have to go through the same testing, the same steps that a domestically trained doctor does post-graduation. The difference is that they just don't do the 2-year residency program. It doesn't make any sense. Evidence shows that immigrant doctors are just as good, if not better, at providing care to patients. So that would be, unfortunately, that's at the state level. There isn't really anything. I mean, the federal government, I guess you could do a full ban on repeating, but I wouldn't necessarily, that's not something that would happen in the real world, but in the debate world, you could try that.
But we have all these candidates for president who claim they can do pretty much anything, right? Just they wave their arm and there's an executive order. But this would be an emergency executive order that would allow
Yeah,
qualified doctors to practice medicine if the insurance providers and others, and the battle would be the status quo. This is the captured economy idea. The
yes,
residencies are a gift to the hospitals of providing huge numbers of hours cheap for them to run their hospital. And then, so that's, I mean,
exactly
no
right.
residency
Yeah,
is corrupt in that sense. It's been captured, but this
yeah,
is one way
a
to,
cartel. Yeah.
yeah, and you could at least, I mean, for practicing for the immigrant community, right? You've got huge numbers of immigrants that can access their own doctors from their own countries here
No,
in the.
that's it. No, that's a point that I think is sort of understated in the immigration conversation. So obviously, immigration is a very politicized issue, but when it comes to healthcare, the immigrants are the ones filling the gaps in our workforce. Beyond just the doctor, I mean, in terms of just hospital workforce shortages, immigrants are filling the gaps there, and we're not letting them fill the gaps in the other parts of healthcare, Medicare, in terms of MDs, DOs. So I think that's a critical part of it, and definitely, if a debater wanted to pull a federal lever on that, whether it's an executive order, whether it's a congressional legislation that requires sort of what I would call universal portability or universal mutual recognition for licenses, which would basically mean that if someone started practicing in Michigan, or sorry, Tennessee, who passed a law, then they could do it in another state, and there's a sort of standardize it. You just get into sort of the federalism debates about like states' rights and all of that. But it is an emergency. We're going to be short almost 150,000 primary care doctors probably in the next 5 years. And we have about that same amount of immigrant doctors that are unemployed or underemployed. So, yeah, I would say that would be a really urgent need, and a good lever to pull.
So would some sort of deregulation, then that would be something to look to.
Yeah. So it's difficult on the federal. A lot of the deregulation needs to happen at the state level. There's uh, so on the federal level, I would definitely zero in on residency funding, GME, graduate medical education funding, and that's Medicare levels. You have a lot of different proposals. Bernie has sort of been, Senator Sanders has sort of been a major proponent of increasing the cap. I would be worried about just increasing the cap without creating additional incentives for primary care, because I think all you're going to do is just add more specialists, which isn't the worst thing in the world, but it's not necessarily the best use of funding if we would just increase the cap. I don't know that there needs to be a cap. I think that Medicare, if there's a good use of Medicare funding at this juncture, it's to incentivize more doctors. So I don't necessarily see that as the worst thing either, but there needs to be a restructuring. Niskanen has sort of called for like a refinancing of Medicare residencies. We have a great report called Unmatched that can be used. I'd say there's probably 10 recommendations in there that could be turned into cases. I'd highly recommend folks to check that one out.
So on the supply side, partly because I work with debaters, I also have this cavalier, wave your arm and make this happen,
Sure.
a legislative fiat. But, some of the big companies in this country, Walgreens, Walmart, they're hugely involved in pharmaceutical distribution, and they're opening little clinics in their places. That's great. There are healthcare clinics, but why couldn't they open their own medical schools? Walmart has enough money and access to expertise to open a Walmart medical school that would provide Walmart trained doctors that are certified to practice in any Walmart, a Walmart. So there's just so many
Yeah.
options to train more people. And it seems to me the guy with the skill to do surgery doesn't need to have the same skill to be a primary care. They need knowledge. And the example I use my glasses, I haven't been to an MD, an ophthalmologist in decades and decades. I go to an optometrist, and that guy's certified, and he doesn't do surgery, but he knows how to see when something like that needs to be done, and he'll recommend me up. So opticians, optometrists, ophthalmologists, you have tiers
Hmm.
of
Yeah.
medical experts. Maybe those people call them nurse practitioners, could provide the primary care service if they were legally allowed to and be many more
Yeah.
constrained.
Yeah. And yeah, that's sort of in the healthcare wonkiness. That's called scope of practice. That's sort of like, allowing nurse NPs, PAs, even I think pharmacists is a huge one. Allowing them to prescribe. Um, and so yeah, that I think that really goes hand in hand. And again, that is a state level fix. Each state has different rules for how. So from the federal level, standardizing that and saying if PAs and MPs meet the minimum standards for practice, or if they in many states, they are trained to do something and they're not allowed to do it once they get it, like that doesn't make any sense. So creating some sort of standardization at the federal fiat level, I think is a great idea for debaters.
Yeah, when I was going to nursing school, because I'm a registered nurse as well, when I was going to nursing school, they had a walk-in clinic that had a couple of physicians in there, but they had an NP in there as well. And the way they got around it, which I know is probably not very legal, but this is a long time ago, the doctor just signed an entire prescription pad, and he trusted the NP to write the prescriptions up to a certain level. And then he would say, okay, if you're going to be doing any Schedule 1 or anything like that, then you need to get his permission. But she had this entire signed prescription pad that she could just write for antibiotics and for mild painkillers and things like that.
Yeah, no, that still happens sometimes, particularly in telehealth. You have a lot of that where essentially PAs are allowed to sort of bill in the name of, as sort of the way I
Yeah.
forget the incident. It's called incident to billing, incident to, and so those, it's incident to the physician, but I'm the PA, and I can, as long as I say that, it's underneath such and such MD, then that works, and that's still the case, and that sort of flexibility is helpful. It also can sometimes create some problems with fraud because
Yes.
people are taking advantage of it, but yeah.
So, so I was invited to give a talk to a credit union program in Jefferson City by a former homeschool debater who works for Cornerstone Credit Unions. Um, and they have federal chartered credit unions and state chartered credit unions. So every state has some that are under the state, others that are under the federal government. Seems to me for hospitals and other medical providers, you could have a federal charter as well as a state charter, and hospitals could choose to be chartered by one or the other. That might be an avenue to get your federal uh, um, systems allowed, like for who can practice medicine and so forth, that they're
Mhm.
federal. And again, it's the insurance companies that should be the ones deciding what they're going to reimburse. But isn't it the hospitals that have a stranglehold? Because you can't practice in that hospital unless they give you the okay. And so they're sort of the,
Yeah, so all of that is sort of determined by market leverage, right? You have if an insurer has a lot of leverage in a marketplace, then they can say, you know, we will only cover this for X amount. And with large leverage on the insurance side, you see reduction in prices because if an insurance company has a lot of leverage, they can say, all right, well, we'll only pay this, and you have to because you need it. At the moment, it's the opposite. Providers have incredible leverage. Not only do they have leverage, they also are beginning to purchase insurers, and then they become the same entity, and that is terrifying. And that's happening. United Health Group now owns 1 in 10 physicians, and is a massive insurer. So there's as a result of sort of like I would say uh, federal incompetence, antitrust, just ignoring healthcare for many years. You've developed one of the most consolidated marketplaces ever in, and therefore it's like the leverage situation is driving prices. It's providers are able to negotiate really high rates, sometimes 400%, 500% higher than Medicare. And without a change in the market dynamics, you're not going to see a reduction in prices. You're just not. There's not, or without, I guess, federal, price capping or a change in the marketplace, you're not going to see any reduction in prices.
Is there a lot of antitrust aspects going on? So I know that with our certificate of need case, they're saying that that is like an antitrust issue that the federal government should step in and say you can't do this.
Yeah, I mean, I think if you're running a case, I think that that's definitely one way to do it, is use the FTC as sort of an enforcement arm to prevent. But the federal government sort of already, because so the Hatch-Waxman Act, was it Hatch-Waxman? I forget the no, it was
Sherman?
yeah. It incentivized, it basically created a punishment if states didn't institute certificate of need. But that, I mean, they removed that, so there's no
Right.
longer any punishment for states that don't have it, and so you could, I guess, use FTC enforcement
Yeah, but
to
35 states are still doing it. There's only 15
right, yeah, no,
states that
exactly,
went away. Yeah.
yeah, and so you could use FTC enforcement to try to like, um, say this is anti-competitive inherently, therefore you need to disband your certificate of need program. That's definitely one way to do it on the federal side. Um, you could also just try to do a case on more FTC enforcement of hospital mergers. I think that would be good. But it's just historically, like the FTC has not been a huge player. They're trying to do more now, but they haven't been in the past. And I do think that I view antitrust enforcement sort of whack-a-mole. And you can just like, you can keep hitting every new thing that comes up. But I view like more, structural change to the marketplace, better market dynamics as a more powerful tool.
Of course, I'm in the promoting economic education, and that's why this incentives and supply and demand are so important.
Yeah.
One of the challenges is people look at the huge healthcare spending as a problem, but of course, the people that receive that money don't see it as a problem. That is their
Yeah.
lifeblood. So you've got all these people in the system that are providing all these services at very high costs. And if you say, well, look, we could do this at half the cost, well, that means half the people lose their jobs or their wages go down or, companies go bankrupt. And so,
Yeah, but that's not necessarily the case, is it? Right? You have uh there's a sort of belief on the healthcare side of what's called like the iron triangle. That is, you have cost, access, and outcomes on three ends of the triangle, and you cannot improve two without hurting another. And so I think part of education on healthcare is saying that's not always true. I think direct primary care is a great example. You can fund direct primary care clinics, and you can improve outcomes, you can improve access, and you can lower costs. Not necessarily in terms of just, yeah, you have to pay for direct primary care if you use Medicaid funding, but over time, I think you see savings. So there, I think part of it is what I would call, and this is sort of a movement largely, is abundance, which is a focus on abundance rather than on scarcity. Yeah, in some cases, there's some reforms that are going to reduce hospital revenue. Sure. I think that as a result of a reduction in hospital revenue, will it be the CEO of the hospital's salary that is the thing that gets cut if hospital revenue reduces? Probably not. It may be other jobs. But the reality is that if that happens, it's because those jobs weren't needed. Administrative spending has increased at a faster rate than employment in healthcare. So there will be other jobs if you take an abundance approach to healthcare. It's about redistributing those jobs to areas that are more effective and more efficient. I don't think that we can just accept the hospital industry argument on the whole, oh, well, everyone's going to lose their job and people need this. And the problem is that they have a lot of leverage because they're the biggest employer in a lot of these districts. Talking on the Hill, there's so many lawmakers where it's just like, this is a great idea, but we can't do anything about it because we have a hospital in our district that's huge, and it sort of owns a lot of these decisions, and it makes sense. As a lawmaker, it's a tough situation to be in, but I definitely don't buy the argument that funding lower cost healthcare options or reductions in hospital revenue that was previously wasteful or ineffective is going to be a net loss, if that makes sense.
Mm-hmm.
So at a crowded restaurant where I was trying to make the case for Indian reservations opening their own hospitals and even medical schools because they have casinos, they can do all this stuff, sell fireworks. Why couldn't they have medical clinics? And the noise in the restaurant, it was confused with having people from India open hospitals in Indian reservations, but that's part of the medical tourism. You can fly to India
Hmm.
and get super high care inexpensively, but those doctors can't come here. Those hospitals can't come here. But what if they could be set up again on an Indian reservation? It sounds crazy, but really, this is the federal government
Yep.
already. Yeah.
No, it's this. I don't think it's crazy at all. I think um, ending the cartel on the way doctors are licensed, the way they are board certified, the way the medical schools they choose, how those schools are funded, I think is probably the most underrated aspect of problems with healthcare. And so any policy that cuts into and incentivizes more options is a great way to make impact on this. I know that we also wanted to talk about the patent reform issue. I'm happy to get into that before
Well,
we
yeah.
before we
Yeah, yeah,
end.
yeah, yeah.
So how about let me ask, that's right. You've written on that and it sounds fascinating. Can we have just a couple minutes of your path? I know when we had Jonathan
Sure.
Wolfson speak at the Civic Summit, he sort of mentioned how he, got invited to do this and then did that. And the next thing he was doing this big stuff. So I met you when you were coaching an ethos debate program at a school in maybe South Carolina. And
Mhm.
that was before you started with the Palmetto Institute, I guess it was, for research. And then you've been to the Milken Institute. And give us a sense of how you
Yeah.
go from a homeschool debater to actually doing this policy work.
Yeah, so to be honest, it started out in just as a homeschool debater, loving doing public policy, and then also trying to participate locally in politics in the election. So I campaigned for a guy who was running for Congress, and he had a primary in my district, and it was someone that we had sort of been connected to through my parents. I think it was just a lawyer that my parents had used in the past, and they're at his law office. They saw a bumper sticker. They're like, "Oh, what's this?" And at the time I sort of loved politics like I love sports. I was like, sure, I'm homeschooled. I have my afternoons to do this kind of stuff. So me and my friend, we would drive around the city, put up signs. We would just hang out at campaign headquarters, make phone calls, and I just really loved it. And I ended up, being able to do more and more. I got to go directly with the candidate to events, and then what happened was the candidate lost. We made it to a runoff, but the candidate lost to at the time it was Mark Sanford, who was a former South Carolina governor,
Hmm.
and then obviously became congressman as a result of winning that primary. But when he won and came into office, because the candidate I was working for at the time had beat him in the county that he was from, my county in Beaufort County, South Carolina, he hired as many people as he could from the campaign to come on to the district office. And so as a result, he hired my boss during the campaign. I say boss, I was a volunteer, obviously, but and she said, "Hey, what if you wanted to intern at the district office?" And so that's kind of how I got started, just working in that area. And so I was a part-time intern, then full-time intern, and then staff member for the first congressional district in South Carolina. And then in 2016, Mark Sanford lost a primary election. And so I was again looking for a job. And that's sort of during that process, I just really realized that I was so dependent on think tanks and their research and their expertise to do anything policy wise in the congressional office. And I was like, I kind of want to be there. I kind of want to be at the beginning of the formations of these ideas rather than have to sort of type them up into a briefing document for a congressman. Not those jobs are really important. It's just sort of my preference was to sort of be on the front end of that. And so I got a job, a think tank at the state level, Palmetto Promise Institute. Did a lot of education work, but also a lot of healthcare work. I sort of became the de facto healthcare person there, and I really liked the healthcare deregulatory work. I was there during COVID, where we got to work directly with the Department of Health and Environmental Control on certificate of need waivers for clinics who wanted to increase bed capacity to deal with the inpatient surge during COVID. And that was really rewarding work. And then I ended up going to school out in California. I got a master's degree in public policy. I realized that if I wanted to kind of become an expert on something, I wanted to get an advanced degree. And so I did that, and I got to write two papers on healthcare reforms, shopping reforms, and then interned with Niskanen and with Milken. Got a full-time job with Milken because I really just wanted to stay in Los Angeles. city gets a bad rap, but it's a beautiful place to live. And I got to live in Santa Monica and walk to the beach. So I didn't want to leave. So I got a job there at Milken, and got to do some research, but I didn't get to do any policy work. So I was sort of, while I was there, I was enjoying it, but I was really just looking for a policy job. And I've been a fan of Niskanen for a long time. And so when I saw they had a healthcare job open up, that was sort of, I went all in on that, tried my best, and now I'm in DC. So that's sort of a little bit of the path.
Cool.
Yeah.
All right. So what about the patent reform?
Yeah. So in terms of as a healthcare reform, I think it's great in that you have, I don't do a whole lot of drug policy. There's all that market is crowded in terms of the people working on drug policy. And there's a good reason. In terms of proportionally out-of-pocket costs, patients spend more out-of-pocket on drugs than they do on hospitals, which is a kind of a surprising statistic to people, considering that drugs make up 10% of spending, whereas hospitals make up 21, 22% of spending. But because hospital negotiates, most of the costs that we pay to hospitals are really just through insurance premiums. For drugs, a lot of it is actually out of pocket. We have to pay for these drugs. And for really life-saving drugs, it's sort of outrageous, the amount that patients have to cover out of pocket. And so a huge part of doing that is to accelerate the market status of generic and biosimilar drugs. Those are drugs that are essentially, you take the brand name version, I think some popular brand names, Wegovy, Ozempic, those are brand names, really incredible innovations, really important that drug makers are doing that, and deservedly cost a lot of money because it takes a lot of resources to come up with ideas like that. But what the FDA does is say, okay, you get a period of market exclusivity where your brand name is protected. No one can create a generic and just go to market right away. There's sort of rules around that. And that is what I would call sort of a government price setting. The patent itself and the exclusivity period is a way of setting the price, rewarding those companies for their innovation. Now, what drug manufacturers and their lawyers have done is they realize that even after that exclusivity period, they could sort of delay even further generic and biosimilars entrance to the market through sort of these patent schemes. So some of them, I think the most popular is what's called a patent thicket. That is when you fortify your brand name patent by filing a bunch of small patents about different parts of the drug, whether it's the manufacturing process, whether it's the way it looks. There's so many different things. And a lot of them actually don't have anything to do with the drug itself or the way it impacts the patient. And so there's sort of a lot of reforms to try to fix that. From a debater's perspective, you could do it from the congressional level, as in you could pass a bill to change some of the process, make it more competitive. Or there's also the USPTO, the Patent and Trademark Office. They're doing their own sets of reforms, and you can do it either way. So there's a bill currently going through Congress, that passed Senate, that would essentially limit the amount of patents that you could file and sort of incentivize these brand name drugs to fortify only the most important parts, because it's a constant balance between incentivizing innovation. You don't want drug manufacturers, you don't want to make it so that they don't have any financial incentive to innovate. You don't want to remove their exclusivity period. Like, there's a reason why we have these things in place, because the US is an incredible innovator in this space. As much as our healthcare system, in terms of our outcomes, are poor compared to other countries, we are innovating in the Medicaid, the pharmaceutical drug space. So don't want to remove that innovation, but there's guardrails you can set. So my piece has kind of an example of two of those: Patent and Trademark Office, and then a congressional one that both would do a lot to help improve the playing field.
Is this the same thing as what people are calling evergreening, or is that something different?
Yeah, evergreening and product copying are similar. That is sort of when you can sort of go from product to product and maintain your exclusivity. Yeah, the patent thicket one is probably the one that has the most political interest, I'd say, right now.
Okay.
So reforms to that, you saw that bill pass the Senate unanimously. Not common to do that. That means that the senators kind of put out floaters to all these offices that said, do you have any reason to oppose this? And so unanimous consent is a risk, because then if one person says no, then it's done. So passing by unanimous consent means that not a single pharma company was believed strongly enough do this. And some of this is because I think one of the interesting things is some of these big pharma companies, Pfizer, for example, also produces generics and biosimilars. So even though they do have brand name drugs that might not necessarily benefit from reforms to patent thickets or changes to that process, they also have generics and biosimilar drugs that they can bring to market faster as a result. So,
Cool.
yeah. So that would apply to both the healthcare one and also folks that have to do work on intellectual property rights. You could there intellectual property rights. So you could apply that to both.
All right.
So
yeah, go ahead.
Are people, I mean, is the Niskanen Institute interested? Are people up above interested in the fact that this homeschool network is debating federal healthcare policy, and you're the resource from the homeschool world? We want to reach more people in more communities. So the idea that you have hundreds of students out there advocating one of the reforms that you wrote or Niskanen wrote or the center wrote, is that of interest, or is it sort of too small to be in the education side rather than?
I will say I can really only speak for myself, and that is it's really exciting for me because I just remember as a debater kind of reading evidence and sort of whenever I was doing that, I was sort of thinking as these names I was reading and quoting as sort of these like people that are up here. And now I realize that I was quoting a bunch of bozos probably because it was people like me. But it's still very exciting for me to kind of think it's like, wow, like I'm writing things that could be used as research and resources for folks because I spent countless hundreds and hundreds of hours just researching, trying to get to the nitty gritty on a lot of this policy stuff. And now I get to do it as a job. So it's really neat for me. I know that other folks on my team, Leah Labresco Sargent, who she does family policy for us. She is also super into debate. She now does adult debates. She debates all the time in DC. There's groups that host these sort of policy debates between two folks that come from different sides of an issue, and she's often in those debates. And so she personally, I think really likes to see, and I think connecting the world as much as possible. I don't. A lot of the folks that do team policy debate, a lot of the folks that did it with me in NCFCA are now in positions to influence policy in Washington and in other states. And so I think it should be. I think there's a strong incentive for think tanks, for even Hill folks to invest in students, because they're likely going to be the ones best positioned to start working on these issues in 10, 20, 30 years. And a lot of the stuff that I work on probably won't happen in my lifetime. You have to be able to pass on some of these ideas to folks who are equally passionate, and that will then be able to work on it after you're gone. So that's one of the hard things about working on federal policy is a lot of it is stuff that you don't necessarily see some of the outcomes until much later on. Whereas at the state level, you can sort of see probably a much more quicker turnaround. But that's what I would say about that.
That reminds me, we had a topic years ago on tort reform for healthcare. That was a STOA topic, or maybe before the split, I've forgotten. Is that so? They're saying that this is a contract issue, not a tort issue, and doctors are doing all this stuff because they're worried about getting sued. Is there a federal tort reform interest now, as there seems like there was 15, 20 years ago when that was a topic?
I don't hear as much about that, but I don't know if that's because there isn't as much momentum versus just because I'm not in those circles. So I don't hear a lot about it. I do hear some talk about some of the malpractice reform stuff, but not a whole lot on that. But there's also a very good chance that I'm just not necessarily in those conversations. Because sometimes you can have sort of a bias towards your issues where it's like, oh, everyone's talking about this. And it's like, well, maybe that's because it's your job to talk about it. So I don't want to say that no one's talking about it, but.
Okay.
Yeah. So I think we're getting close to probably you're like overtime here at this point.
No worries.
How can people get in touch with, or I'm sure there's a website. How do they get a hold of your papers and those types of things?
Yeah, so I will say, if anyone listening, I'm happy to be a resource as much as possible. I love giving back to sort of a community that kind of is, I'd say, the reason I'm doing what I do now. And NiskanenCenter.org is definitely where you can find all of the work. My page is on there with my email address. I'd say that's probably the best place to start. shoot me an email, and I'm happy to help out. If anyone wants to send over a case and just get some thoughts on it, I'm happy to do that as well. So you can find my
That
email
could
on
be
the website.
dangerous.
I know, I know.
That may be a full-time job then at that.
Well, hey, great talking to you. Thank you for taking time to reach out to connect with students. And this is their topic for a year. They're going to be deep into it, just like you were when you were in your topics,
Yeah.
in your years of debate. So
Yeah, no, that's great. Well,
Yeah.
thanks, Greg and Stephen, for your time. I really appreciate it.
Yeah, and I've got students that I coach all over the country. I'm going to send them to you. So
Great. No, happy
yeah.
to help however I can.
All right.
okay.
All right,
Thank
thank
you.
you.